Hello, welcome my friends and colleagues in new video of our YouTube channel. Number 1 Doctor. Today we'll have a lecture. Hope you enjoy, get benefits. But before we start the lecture, do not forget to subscribe to our YouTube channel Number 1 Doctor. Like the video, share the video on social media. Follow us on our social accounts below the description. If you have any ideas, leave it in comments below the video.
Okay, doctor. Can we start the lecture now?
Okay, we will start soon.
Hello, thanks for watching this video today. The topic that we have today, like I've written, is hemorrhoids. So let's start, as we always do, with the definition. So the definition of hemorrhoids is engorgement of the venous plexus in the anal canal. So the best way to start is going to be with the anatomy of the anal canal. Now the anal canal, so I have a diagram here of the anal canal, and the most important part of the anal canal is going to be this line that I'm drawing here. That's called the dentate, or also known as the pectinate line. And this is really important because early on in embryology, it's a combination of two different embryological parts. Above the pectinate line, so let me zoom in here. Above the pectinate line, you have the endoderm. And below the pectinate line, you have the ectoderm. Now this pen isn't really working too well, so what I'm going to just do is just draw a little table. And so what we'll do is we can just draw a table, and we'll write above for above the pectinate line, and below for below the pectinate line. And then we'll just kind of compare and contrast the different features above and below. So the first thing is, above is going to be derived from the endoderm of the embryological tissue, and below is going to be derived from the ectoderm of the embryological tissue. And so what this also means is that the type of cells are going to be different. So in the endoderm, you have the columnar cells, and in the, sorry, not endoderm, but above the pectinate line, and below the pectinate line, you have the squamous cells. And just as a side note, this also links into pathology related to cancer. So generally above the pectinate line, you get adenocarcinomas, and below the pectinate line, you get squamous carcinomas. And this is just because of the histology. Now, since above the pectinate line is derived from the endoderm, there isn't no necessarily somatic sensation. So there is no pain above the pectinate line. However, below the pectinate line, this is going to be pretty much your skin. And so your skin has somatic sensation. And so this is going to be, you will feel pain. And primarily the nerve that this sense goes through is the pudendal nerve. So the pudendal nerve is the nerve involved in feeling this pain. When it comes to pathology that we're going to talk about today with hemorrhoids, it is, I guess one key feature is hemorrhoids that are above the pectinate line oftentimes result in prolapse, whereas hemorrhoids below the pectinate line result in thrombosis. And so since we're already kind of jumped the gun here, hemorrhoids above the pectinate line are also known as internal hemorrhoids, and below the pectinate line are called external hemorrhoids. So that's kind of a premonition of what we're going to talk about later. Okay, so now what we'll talk about is the definite causes, or the etiology of hemorrhoids. The first etiology is going to be related to defecation, because that's the primary function of the anal canal. So generally patients who have low fiber diets, what will happen is, because they don't have enough fiber in their diet, they tend to become constipated. And when the patient becomes constipated, they strain very heavily, and this can lead to increased abdominal pressure, and it can engorge the veins of the anal canal. And we'll talk about those veins specifically in a little bit. Also, constant diarrhea can agitate the walls of the anal canal, and that can lead to this type of engorgement of the veins. And also, believe it or not, prolonged lavatory sitting. And these are generally people who, when they use the toilet, they end up reading a book for hours or whatever. This can block the flow around the anal canal, and this is one of the causes for hemorrhoids. So if you're one of those people, you might want to find another place to read a book. Also, trauma can lead to it, and even age. As you get older, some of the support structures tend to weaken up. Besides defecation, there are some secondary causes, so other pathologies that can lead to hemorrhoids. The first is going to be a hypertonic sphincter, and again, when a patient has a hypertonic sphincter, it makes them push harder while they're defecating, and then this can cause increased abdominal pressure, which can lead to engorgement of those anal vessels. Pregnancy can also lead to it, and again, pregnancy a lot of times is causing increased abdominal pressure, and that's what will cause. And of course, portal hypertension, oftentimes caused by liver cirrhosis. Again, backup flow, and then of course we know portal hypertension can also cause esophageal varices, anal varices, and even the umbilical varices. So that's just your general causes. Now we can go back into different types, and we're kind of, and when we're talking about types, I've kind of already alluded to it earlier. So here, let's take a diagram of the, here we go. So as you can see, here's the pectinate line, and hemorrhoids that are above the pectinate line, so such as this one here, are going to be internal hemorrhoids. And hemorrhoids, so this is the pectinate line, so below here and outside the anal canal is going to be your external hemorrhoids. So that's how they're divided. And so when we're discussing hemorrhoids today, what I'm going to do is I'm going to just make it in the form of a table. So I'll put internal on one side and external on the other side here. So we know the veins are involved, so it's important to go over which actual veins we have in the canal. In the internal area, we have something called anal cushions, and in the external, we just have circumferential veins. And so here, right here, I've kind of drawn a diagram of the actual blood supply of the internal and external canal. And so what you can see is, you can see this plexuses 1, 2, 3. These 3 plexuses are the anal cushions that are found here in the internal canal. And out here in the external here, this is the circumferential vein. And so this is the major site of pathology when we start talking about hemorrhoids. And so the one right here is called the left lower plexus of veins, or the left lower anal cushion. The one down here is called the right posterior anal cushion, and the one on the top is called the right anterior anal cushion. And so right away, since this is anterior, you know your genitalia is on this side, and this is kind of your backside there. So these are your 3 plexuses that commonly get engorged. And so since this is the main locations, generally what you have is you have hemorrhoids. You get, let me see, okay, here you go. So you get what I've drawn here is, if you think of this as a clock, this being 12 o'clock, you'll generally get one hemorrhoid at the 3 o'clock position, you'll get one hemorrhoid at the 7 o'clock position, and 11 o'clock position. So the thing you want to remember is 3, 7, and 11 o'clock positions is where you generally get the hemorrhoids bulging. However, there are some minor tufts in between. So in between these main plexuses, these are minor tufts, and these minor tufts can have hemorrhoids. So it's not necessarily 3, 7, 11, but those are the most common, and those are the largest. So what we can do now, before I continue, mixed hemorrhoids is basically when you have a hemorrhoid that starts off an internal, crosses the pectinate line, goes into external. So if it goes into both, that's called a mixed hemorrhoid. Okay, so what we'll do now is we'll continue this chart that we started, and we'll look at the different grades of internal hemorrhoids. Internal hemorrhoids, since they prolapse, they have different grades based upon how much they prolapse. So the first one here is grade 1, and in grade 1 there is no prolapse. So you can see there's like just these 2 little like nuggets there, and so there is no real prolapse. And then on the right hand side we have a picture there, and you can see when you visibly look at the anus, there's really nothing there to see from the outside. In 2, you can see that the hemorrhoid is bulging out, so kind of highlighted in green there. However, it's bulging out, and generally what happens when they defecate, it will come down. However, it'll spontaneously regress. So you have spontaneous regression is a key feature of grade 2. And you can see here that the grade 2 is, you can actually kind of see visibly. So grade 3, I've kind of highlighted it there. In grade 3, whenever they defecate, the prolapse will increase. However, with digitally, they can push it back in. And so you can see here, it's it's protruding much more than grade 2. So digitally, they can pull back to grade 3. Now the final most severe grade is grade 4. And so you can see it's the whole thing bulging out there. And in grade 4, the distinguishing feature between grade 3 and grade 4 is if you apply pressure up this way, it won't reduce. It'll just stay out. So grade 3, you could manually regress it. However, in grade 4, it's no way to regress it. So, and you can see how big that is, and you can just see as you go down, it's become bigger and bigger and more visible. So that's internal. We can go back to external. So we know that external is in the circumferential veins, and so they can occur anywhere. They don't have the same 3, 7, 11 o'clock thing. The biggest problem with external is thrombosis. And so here's an image here of an external hemorrhage, and you can see kind of bluish discoloration. And so that is thrombosis right there. So you can see that. And what happens oftentimes is it begins to erode the skin, and that can eventually lead to bleeding, bright red blood. And so that's a common feature of external hemorrhoids. And when it becomes chronic, they can actually produce skin tags. And so you can see skin tags here, and the problem with skin tags is there's many crevices. So you have like one here, there, we have like 3, 4, and a long one there. And so what can happen is hygiene becomes an issue. So when they defecate, the fecal matter gets trapped in this area. That can lead to intense itching and of course, infections as well, and erosion. Okay, so as you can see, external hemorrhoids isn't as bad as internal hemorrhoids, because internal hemorrhoids does have that prolapse, and the prolapse can lead to different complications. So we'll kind of talk about that right now. So when you have a prolapse, what can happen is oftentimes you can get the external sphincter can compress it, and so when the external sphincter compresses it, you get decreased venous return, and that leads to strangulation. And so once you have strangulation of the actual prolapse piece, I guess you could say, this can either lead to fibrosis of that piece or gangrene of that piece. And so of course if you have gangrene, that's going to be much more serious. You need to do surgery, and if you have fibrosis, I guess it's not as serious. But once you have strangulation, what can also occur is you can have that piece ulcerate, or it can thrombose. And if it ulcerates, if it thromboses, that can lead to pain, and if it ulcerates, that can lead to bleeding. And this is the common symptoms of hemorrhoid is pain and bleeding, and even pruritus as well. But that's more due to just kind of some of the mucosa going out and causing itchiness. So generally, that's going to be your complication related to prolapse, especially if it's been there for a long time and it gets trapped into the sphincter. Okay, so how do we diagnose it? So let's kind of extend that there. So we're done with that. So now we move on to diagnosis. First of all, you're going to want to do a visual inspection. And you do a visual inspection by first putting the patient in the lateral left decubitus position. And generally, if they have an external hemorrhoid, you can see it right away. However, while you're over there, you do want to try to rule out abscesses and fissures. And this is because many patients will come in saying, I have a hemorrhoid, but it's not a hemorrhoid. It's just a common condition that they know of. They might just have a fissure or an abscess. After the visual inspection is done, you want to proceed to a digital rectal exam. And so in a digital rectal exam, in a digital rectal exam, the first thing you want to check is for the tone of the anal canal. And you also want to look for any tenderness. And one thing you do want to remember that internal hemorrhoids oftentimes are not palpable. So just because you can't palpate something doesn't mean you can rule out hemorrhoids. And so obviously if that's the case, then we're going to have to also do an anoscopy, also known as proctoscopy. And what you generally will find is like a bulging blue veins. And so if you see that, then you pretty much diagnose internal hemorrhoids at that point. There's no really need to do any more investigations, labs. imaging. Sometimes if it's been chronic or if it's really bloody, you can do a CBC to rule out anemia, but that's very rare, so not commonly done. So once you diagnose it, of course, we want to go into treatment. So we can talk about that. The first line of treatment is going to be conservative treatment, and you're going to want to do that whenever it's stage one. Not stage one, let's say that. Whenever you have a stage one, you definitely want to start off with conservative. Maybe even stage two, you want to start off with conservative. And the first step is going to be diet and fiber. So as soon as you can change their diet, maybe give some fiber supplements, get exercise. That can help some of the symptoms a lot, and actually it has been shown to actually decrease the hematochezia that they might have. And hematochezia just means blood in the feces. And with regards to pruritus, which does occur sometimes, oftentimes you can give cream. Hydrocortisone is very common, and sitz bath is also helpful for them, to kind of alleviate some of the symptomatic issues that's going on. So once you try conservative treatment, and it, if say it doesn't work, then you do need to go into minimally invasive treatment. And so minimally invasive is basically any type of procedure that can be done in the OPD clinic, so the outpatient clinic. You can do it there. The most common one, most popular, is the rubber band ligation. And rubber band ligation can work for stage 1, 2, or 3. However, it doesn't work for 4. And so what you do in rubber band ligation, so here I have a diagram of what happens. You have this device here called a ligator. You clamp the hemorrhoid, and then you push the ligator up above the hemorrhoid, so suck it in, and you see this black area here. These are rubber bands. You take them off, and these rubber bands will clamp the hemorrhoid shut. And so after a while, it stops the blood flow, and it'll just come right off. So very quick, non-invasive, painless way to treat the condition. So this is the most popular way to do it. However, there are other options for whatever reasons that needs to be done. One of them being laser photocoagulation, which they use high intensity light beams, sclerotherapy, where they sclerose the actual hemorrhoid, and finally you have cryosurgery, where they make it really cold. And so you can use this those three on stage 1 and stage 2, not stage 3 or 4. Surgery. Surgery is generally reserved for cases where it's stage 3 or stage 4, and sometimes 2 if the conservative management and minimally invasive management didn't work. You also want to do this if they have thrombosis. You want to do this if there's ulceration, if you find any bleeding, or if there's gangrene. So any of those 4 conditions can automatic surgery. The common surgeries that are done is known as hemorrhoidectomies. So you can have an open or a closed hemorrhoidectomy. These were pretty effective. They have about a 95% cure rate, and infection rates really low. However, there is another method which is called the stapled hemorrhoidectomy. This has a higher recurrence rate. However, there's less pain and it's a shorter stay. So some patients prefer this. Now, with regards to hemorrhoids, it's a very common condition, and since it's very common, there's many different devices, procedures being developed. So there's definitely many more. I couldn't get into all of them, and that goes with minimally invasive as well. There's definitely many more going on. So hope you enjoyed the discussion. See you in the next video. Thanks.
Thanks for watching. Hope to see you again in next lectures and presentations. Do not forget to share and like the video. With my best wishes, Dr. Ahmad, and visit my website, dratf.net.